Well, thank you for the opportunity to speak today and to share some of this information. My name's Nate Call. I'm from Emory University School of Medicine, the Department of Peds, and I'm also the clinical director at Marcus Autism Center. Today, I'm going to be talking about challenging behavior that it can be exhibited by kids with autism spectrum disorder, and presenting a variety of different studies that are underway at our center that I'm engaged in with my team. And really what I'm hoping to do is to kind of share different types of studies that are underway and the ways in which the type of work that we do really fits into several different niches. So different methodologies, different approaches to answering questions around that are all important when it comes to figuring out how to best work with individuals with autism who engage in challenging behaviors. These are my disclosures. Nothing really too relevant here. Not receiving any funding from anyone who's paying me to say anything in particular. And so I'm going to jump right in with talking a little bit about just the way in which folks who come from the perspective that my team does, which is more of an ABA or behavior analytic approach or think about challenging behavior, because I think this is going to be relevant for some of the other stuff that we talk about later on. And so when I think about challenging behaviors, there's a long history of behavioral interventions. And here I'm talking about behavioral interventions to mean manipulating different elements of the environment, manipulating consequences or antecedents, things that kind of evoke behavior or that come after the behavior, as opposed to like medications, for example. So behavioral interventions, though, have a long history of being used to try to address challenging behaviors that might be exhibited by folks with autism. And I can tell you that my experience as a clinician is one in which, I've talked to a lot of families and we might hear them tell us about what challenges they've been dealing with on the part of their loved one or their child. I work in the Department of Pediatrics, so it's usually their kid. I'm going to probably use those terms throughout this talk, but doesn't necessarily pertain just to children. But regardless, have a conversation with a family and they'll tell me what's going on with their kid, and I'll say, well, what have you tried in the past? And they might say, well, we've tried, I don't know, timeout, or we've tried, a token system or something like that. And then you ask the next question, which is, well, how did it go? Did it work? Or what was the outcome? And what you tend to hear is kind of a mixed bag. Well, it kind of worked for a little while, and then it kind of eventually fell apart, or it seemed to work sometimes, but not all the time. And so that is by far the most common response to that question of whether or not these behavioral treatments seem to work. And yet, if you look at the literature, there's lots of examples of those types of interventions having been shown to be effective. And really what they're showing is that it is possible for these to be highly effective. But when you talk to folks in the real world, the most common refrain I hear, and maybe it's, the ones where it's really working well, they never come and see me. But what I hear a lot is, well, kind of, sort of, but not consistently, or for some individuals and not others. And there's a hypothesis that I have about why that's likely the case. And that is that these interventions tend to be applied in a way that is, or selected that in a way that is not necessarily taking into account the function of the behavior. And when I say function, what I mean is the purpose that the behavior serves for the individual. And there's a ton of research really going back to the 80s and even a little bit before that, demonstrating that the function of the behavior is critically important when it comes to choosing a particular intervention. And I can go into hours and hours of lecture that I've given in different settings to talk about that and that literature in particular. But suffice to say that is really probably the determining factor about whether any particular behavioral intervention is likely to be effective or not, whether it takes into account the reason that it's occurring. And let me give you just a real quick example. These are some data from a functional analysis. This is the type of assessment that we do to identify why a particular challenging behavior might be occurring. This was a young man who was aggressive and disruptive, would destroy items, was very aggressive within the home. And each one of these data points represents a 10-minute session. So you can look and see on this y-axis here, we're seeing episodes of aggression in as many as 4 or more per minute. So that's pretty high frequency, and I can tell you it was pretty high intensity aggression. But what's important to know here is that each one of these different symbols represents a different condition, that something different was going on within those 10 minutes. So for example, if you look at these closed circles, data point 1, this is representing a control condition, what we call like a free play, in which the child had free access to preferred items. Nobody was asking him to do anything he didn't want to do. He's getting lots of attention. And if you look at all of the closed circles, they're laying right along this x-axis. So this would indicate that no problem behavior was occurring as long as that was the state of affairs. But then you look at the very next session, it's a closed square. This is a session in which, or a condition in which, access to preferred items was being restricted. And we think about these types of functional analyses as almost an analog to a situation that might occur in the real world. And we're looking for a reaction, much in the way that, some people have called this the behavioral allergy test. In essence, you go to your rheumatologist or whomever, and they prick your skin with 50 different things. They look for where there's a response. We're essentially doing the same thing by setting up conditions that would be analogous to situations that occur in the real world, but also acknowledging that in the real world, there's just too many variables going on at once. You go to the grocery store and your child has a tantrum, and it's really hard to isolate why that one tantrum occurred on that one day, because there's so many things that are going on. And you've got, was that tantrum because we walked past the candy aisle, or there's chips over there, or the clerk made a face at the child, or there's balloons, or you just can't really isolate what caused that particular episode. And so what these types of analyses are designed to do is to distill those situations into very isolated conditions that test out one of those variables at a time. And so again, in these closed square data points, this is where access to a preferred item is being restricted. And so in this case, I can tell you that for this young man, we were identified that he really preferred an iPad. And so he would have free access to the iPad. And then someone would come over and say, you know what, buddy, we got to put the iPad away, as happens in the real world, right? You go to school, you can't have your iPad all the time. At home, every so often, the put away or the batteries die. So someone came over, a therapist, and said, we got to put this away for just a second and remove the iPad. If the aggressive or disruptive behavior occurred, they immediately returned that. He got it for 30 seconds. We're trying to control for as many variables as we can. That includes the fact that, he's getting a precise amount of access to the thing, so that we can compare apples to apples with some of these other conditions. And sure enough, if you see in that initial condition where we restricted access to the item, we saw a little bit of problem behavior, it dropped down to 0, but then it started to occur pretty reliably. And then in another condition, this is the open squares. You look at session 5. This was the same thing, but we were restricting attention instead of a preferred item. So saying, you know what, you hang out over there. I got to go do some paperwork, and leaving him alone. And then in these two conditions with triangles, these were different types of tasks. So again, analogous to a situation where someone might say, time to do some homework or time to do a self-care task, and presenting the demand. And then if the problem behavior occurred, they would back off and leave him alone for a few minutes to see how he reacted in a demand context. And sure enough, in this situation, we actually saw pretty elevated rates of problem behavior, aggression, and disruption. And so from these data, we concluded that his problem behavior was occurring in the context of restricted access to preferred items, and that the behavior is likely maintained by gaining access to items, and that it's also maintained by avoiding or escaping from a non-preferred activity like a task. And so this is a situation in which this tells us a lot about what is capable of maintaining these behaviors. And so you can see how certain contexts implementing a treatment might not be very effective. So let's go back to using timeout. Well, in the context of losing access to an iPad, you're being put in timeout because you're aggressive and you don't have your iPad anymore. That could actually be pretty effective. But in a context of demands where we're telling him you got to do some schoolwork, and then he is aggressive and someone says, never mind, take a break, go in timeout, right? Like that's exactly the wrong thing to do, which would be a really clear indicator of why you might expect a single behavioral intervention to be only intermittently effective for this child's problem behavior. That is, it's going to have to match the function of the behavior. And these types of analyses are really critically important to understanding what it is that we want to do to try to treat those behaviors. Now, this is exactly what we did for this young man. So I told you we had two functions. We actually had two different treatments. One treatment to focus on when his iPad had to be restricted, and one treatment to work on demands. These are the data that are focused on the iPad or restricting access to preferred items. So here you can see a baseline where we're recording how much problem behavior we saw when someone was restricting that iPad for 30 seconds at a time. And you see it's pretty elevated. And so the next thing we did was we taught him a communication response. This was a young man with autism who wasn't very effective at communicating or requesting preferred things. And so we taught him a response. We taught him to request the iPad. And in his case, we weren't necessarily worried about the most eloquent language. We weren't necessarily worried about it being even particularly understandable. We actually taught him to hand over a card that said iPad, please, with the idea being that, let's get the behavior under control. Let's get him to stop beating people up. And then we can go back and focus on getting this to be a little more socially acknowledged form of communication. But when we did that, you can see that the problem behavior, that's the FCT or functional communication training phase, problem behavior dropped out to near 0 rates. We then basically took away the card to see what happened. Problem behavior came back. So we know it's not just the behavior is getting better because it's something extraneous. It wasn't just Tuesday and he loves tacos because it's Taco Tuesday. It's when we take the card away, things get bad again. returned to giving him access to the card, and the problem behavior just dropped right out. These are the same sessions, but just the communication data. So how often was he handing over the card? And we saw that, and actually it wasn't that we took away the card, we just stopped honoring the card. He could hand it and they wouldn't give him the iPad when he did. And so you can see here again that the communication seemed to correlate with the treatment being in place or not. So this looks really good, but you can probably spot the flaw right away, which is we still getting the iPad every time he asks for it. That's not really the world that we live in, that, just because we take the iPad away for 30 seconds and give it back when he asks, that's not really solving this family's problem. And so we moved to a strategy. This is just condensing those same data into a smaller frame, moved to a scenario where we essentially did the same thing, but set up two different scenarios. One in which, these are the communication data, one in which there's the presence of a green card or a red card in his case. In the presence of the red card, when the red card was out, if he handed over his card asking for his iPad, he didn't get it. Somebody said, sorry, buddy, not right now. He got to wait for just a second. And then when the green card was out, if he handed over the iPad please card, then he got his iPad. And initially we started out with a really brief interval. You can see if you look closely, this says 80 seconds. So the red card would only be out for 80 seconds at a time, 80 seconds at a time, where if he requested it, he wouldn't get it. But then immediately after those 80 seconds, we'd switch to green. He would have the green card for, I think it was about 5 minutes. And then we'd switch back to 80 and go back and forth like that. And you can see that when we did that, we did see a little reemergence of problem behavior. You can also see that early on, the requests were happening equivalently, whether it was a red card or green card. But eventually, within about 4 sessions, he started to really only make the request in the presence of the green cards. In this case, the green card is the dark triangles, and the red card is the white triangles. So pretty quickly we get to a point where he's only requesting in the presence of the green card. He's very infrequently requesting in the presence of the red card, and problem behavior is not really occurring in either case. And then it's just a matter of gradually increasing the period of time when the red card was out. And we eventually got to a point where it was 15 minutes of red card, which is about enough time for mom to start to take over. And that's when we trained this caregiver to implement this strategy. And she eventually 45 minutes, where she could go 45 minutes at a time where he doesn't have his iPad. 45 minutes, that's enough time to work on some tasks, work on, run into the store and out again, that type of thing. And so this is the type of treatment that we use oftentimes to try to address these challenging behaviors. Now, I want to talk about the different types of research then that we engage in our lab, and there are other folks doing a lot of this work as well, and the different types of work that are happening to try to advance this type of clinical care. And so the first is what I would call just serendipitous research. So we take a lot of data. You saw those data that I just showed. Those are data that we're collecting clinically because it helps inform the approach. We were able to use those data to decide when do you increase the duration of the red card. We're using those data to decide, is this working or not? And so because we have data like these, well, those are pretty publishable, right? And so we've actually published that exact data set in a journal that focuses on small n methodologies to demonstrate these types of effects. And in this case, we were able to demonstrate not just that it's possible, but we used a slightly different way to try to do this type of work. It's called a multiple schedule. We used a slightly different approach to fading out the duration of the red card. And so this is publishable within certain journals that really have a focus like this. And I think that this is a really important type of research, because what it does is this is where innovation happens, right? This was a kid who shows up, kid's got a challenge that we got to deal with. We have to figure out a way to solve that problem. We adapt our procedures so that we figure out a way to do this and to test out a theory about what we think could be effective. And so these types of studies, or these types of case studies, are really effective for showing what's possible and helping us be innovative in solving clinical problems that present themselves on our front door. I mean, frankly, one of the things I really enjoy about doing this type of work is that our center has become the kind of place where, if a kid shows up with a new problem, we don't say, we don't do that, sorry. We say, well, we didn't do that yesterday, but we do today because we're going to figure out how we're going to solve that problem. Now, oftentimes that then leads to a different type of work where we're being a little more systematic in how we approach the problem. Instead of just saying, well, this is a new problem, a kid presents themselves at our door and we've got to figure out how to make their life better somehow. Sometimes we actually have a theory around, we might take an approach to produce a change, and we develop something a priori. This is an example of some of those data. So one example of a serendipitous case was this first data set on the top, right, where we actually saw a young man who came to our front door, and the parents said, well, we know you have a toileting clinic, but our toileting clinic is, like a lot of toileting clinics, pretty focused on urination. You didn't think you were going to come to hear all about, pee and poop, but I'm sorry, that's one of the challenges that families deal with. And that meant that we wanted to be helpful to them. And our urination clinic is pretty successful. In the same Fox and Azrin 1970 whatever approach that's been around for a long time, which is sit a kid on a toilet a lot. If they happen to go, you give them something really reinforcing, and you do that enough times, and you're often going. No pun intended, but frankly, that's the biggest reason to get involved in this work is the puns, because really you can have quite a bit of fun with that. But there are certain things that you can do to boost your chances, right? You sit a kid enough, you'll eventually see them urinate, but unless you're going to sit the kid on the toilet all day, you're not going to have the success. So you do things like fluid loading, give them lots to drink so they pee all day long, so you have a higher chance of catching that first urination on the toilet. We had a kid who showed up where the parents said, urination's not our problem. He's fully continent for urinations, but he had to be fully sedated every 3 weeks to get cleaned out because he was so constipated because he wouldn't have bowel movements on the toilet. And so working with our GI doc, again, we didn't do that yesterday, but we do now. We're going to figure out a solution for that kid. And the GI helped us figure out that, there are medications that can be tried. People have used things like laxatives in the past, and laxatives will make sure that a child who's constipated will go, but it doesn't help with the timing, right? And again, unless you're going to sit a kid for 24 hours, one of the real differences between bowel movements and urinations is just fewer chances per day. So what the GI recommended to us is that we actually use a glycerin suppository because it can help with the timing. So sure enough, this first data set, Albert, we would administer a glycerin suppository. We started out with a full dose and pretty quickly saw that he was having bowel movements on the toilet, which we could reinforce. And then he was more likely the next day. We gradually faded out that medication by decreasing the dose, and he was fully toilet trained within about 10 days. So then we have a protocol, and that meant that the next time we saw some kids like that, we actually used that same protocol. They were effective. We were able to be effective with both of those kids as well. And so that meant that we were able to systematically approach this problem and apply a protocol sequentially to each kid who came through. Now, I think about, serendipitous research versus systematic development, right? So you've got a protocol and you're running it with kids versus you're just kind of problem solving for a case that you're seeing in the clinic. Again, when it comes to the serendipitous research, the real advantage is it's really good for showing what's possible. And when I'm working with one kid, that's what I want to know. I want to know what can be achieved on behalf of this child and their family. And again, it's really conducive to innovation. But the downside is the small sample size really limits conclusions that can be made about external validity. So just because I was successful with this kid doesn't mean it's going to be successful with the next or the next, which also raises questions about selection bias. And there is some literature out there that shows that this behavior analytic literature in particular is susceptible to this concern of publication bias, wherein, well, just because you had success with one kid and it's published in one of these small N journals, well, that doesn't mean that someone else hasn't done the exact same thing with 7 or 8 or 100 other kids and hasn't ever been published because the results weren't very good. And so that's where that's a real area of concern. Another is this concern about, I believe that there are diminishing returns on subsequent single case demonstrations. That is, demonstrating the first time that we were able to toilet train a kid who was, having to be sedated because he was so constipated, can be really impactful. Again, with the puns, right? That can have a really big impact on the literature. But doing another single subject study, well, that still might be great because it replicates a previous finding. But doing the 5th and the 6th replication of a single subject study doesn't have the same impact on the literature. It's just not as important. It's not having as big of a influence on people's, it's not new and different enough. It's not really adding as much to the literature, right? You're getting these diminishing returns. And that's where I think it becomes important to start thinking more broadly. And as somebody who works in this field of behavior analysis, I can say this is where too often that field of behavior analysis kind of stops, right? So maybe do some serendipitous data sets. Maybe you're getting some systematic protocols that are being implemented consistently, but the field just isn't really moving beyond that very often. And so you're seeing lots and lots of examples of, pick your intervention, verbal behavior, teaching skills to kids with autism, addressing challenging behavior, a lot of, incremental improvements or incremental advancements, but really not doing the next step of studying some important questions around, well, how externally valid is this? Can it be generalized? What is the probability of an effect? And so that's where some work is just getting started in the field in terms of consecutive controlled case series analyses. These are really just demonstrations of outcomes for a data set without necessarily the control of a randomized controlled trial. So let me give you one example. One of the big challenges that I see that families deal with is pica. Kids who consume inedible objects. I don't know if you can see on your screen, but this is an x-ray of a kid who'd swallowed a safety pin. It's open in his esophagus right there. Pretty dangerous behavior. I always tell folks, if you want to see a really cool x-ray collection, I'm your guy, because of all the things that kids have swallowed that we've treated. And within the field that I work in, people have a pretty good idea about how you go about treating pica. Again, one of the first things that people used to do is to do a functional analysis like the one I described before. Hold on a second, you're saying to yourself, wait a minute, that meant evoking the behavior on purpose and trying to see what causes it, what the function of the behavior is. How do you evoke pica? How do you allow that to happen? That's a really dangerous behavior. Great question, I say. And the answer is you set up a room and you bait it with things that are safe to consume, but that don't necessarily look like food. We actually have what we call the pica cookbook. It's all of the different things that don't look like food items that are still safe to eat. Things like, we actually get a lot of stuff from an Asian grocery store. There's starches that look like rocks, and there's seaweed looks like string and that kind of thing. They're safe to eat, but that look like string and rocks. So we bait the room, and that way we can see the pica occur without putting the individual at risk. And so that's a process, and there have been treatments based on that for a while. But when we went back and looked at that literature, there are a handful of studies, but the largest data set had 3 participants in it. So again, the question is, there's maybe 3 or 4 studies showing that that approach can treat pica effectively. But how many other times have people tried to treat pica the exact same way and been unsuccessful, but couldn't get their results published? Because again, there's this problem of publication bias. And so what we did is we just went through our data archive and said consecutively, every kid who walked through the door over a 5-year span who had pica as their presenting problem, what was the outcome? Good, bad, indifferent, ugly, right? We want to know good, bad, or ugly. What are the outcomes? So we had 11 kids that we had treated for pica in that span. And when we looked at their outcomes, we saw that we had a really pretty positive effect, about a 1.8 effect size, which is a pretty significant effect, right? That's, I think about the effect size for methylphenidate, Ritalin for ADHD is about 0.6 in the literature that I've looked at. That's considered empirically supported. And so this is 3 times more effective than that. That's a pretty good outcome, but that's important to know, right? Because what that told us was it wasn't that every kid was 100% successful, but it did tell us that even if you use this systematic approach, that the probability of having a good outcome is pretty high. Now, again, some limitations, and I'll talk about that in a second, no control group, but in terms of advancing towards starting to look at the probability of certain effects, that's an important incremental step, and it doesn't necessarily require the funding and that to do something like an RCT. And so we've done several of these at this point. We've done one on treatment of elopement, treatment of enuresis, as well as on interventions themselves, things like token economies and how effective are those. We've also looked at relapse and looked at how prevalent might relapse be for these behavioral interventions, and how often does that occur using these consecutive controlled case series analyses. And I would encourage you to look, if you're interested in this, look at the work of Louis Hagopian, who's really had a review paper recently, defined this type of data set within this literature, and is really advancing it quite nicely. So again, this consecutive case series, it's an improvement upon some of these small N designs, but still has some limitations. And that's where really starting to push towards efficacy trials becomes really important. And again, that's an area where within the behavior analytic literature, there's just not been a whole lot done in this. And this is something that we're trying to advance within our area. That example I gave earlier of treating encopresis. So we had 3 kids where we had success. The next step was to do a clinical trial. And we did initially a small one with 20 kids as a waitlist control, 10 per group, just to show feasibility and pretty good outcomes. We're now in the midst of a large RCT. It is a 4-year study with 150 kids where we're hoping to demonstrate that same protocol can be effective at scale, and that that treatment can be effective, that it's a high probability of effect, that these weren't just one-off outcomes that we got lucky. This is actually, if you follow this protocol reliably, you can expect, what effect can you expect to see? And so we've got other efficacy trials that we're doing now. We're doing another efficacy trial, again, similarly based on treating elopement. I mentioned the one on encopresis. We've also done efficacy trials on using telehealth to treat challenging behavior for families who live in remote and outlying areas. So these are areas where, again, we're doing this work. I hope to see that more behavior analysts will start to adopt this approach and start to understand that this is an important area of work, and that just because there's this history of focusing on small n methodologies within behavior analysis, that doesn't mean that this isn't also really important. So once we do efficacy trials, I think there are other areas of research that behavior analysis probably needs to be working in. One of those is measure development. When I talk about challenging behavior, most of the work that we do, I mentioned that we take a lot of data. This tends to be human observation. So you've got an observer on one side of a one-way mirror watching and coding, or maybe watching a video and recording what they're seeing. And there's some real limitations to that approach. One is the behavior sometimes can be covert. Had a kid who would, she literally ate her windowsill. Speaking of pica, she ate most of the wood in her windowsill, but would only do it when people were around. And as soon as when no one was around, as soon as someone came by, she would stop. And so we really couldn't get any observations to see what was going on. We put a camera in the room. She was very attuned to the camera. And when the camera's little red light was on, she wouldn't do anything, but we would go back and there was a permanent product of wood missing from her windowsill. And so that's one example, but also low frequency behavior. So it might not be covert, but it might only occur very infrequently. And that again is not really conducive to sitting and watching with your clipboard. If something only occurs once a month, you got to watch for a month to see 1 or 2 instances of behavior. The other issue is that, we tend to define these behaviors in ways that two people can agree it occurred or didn't. And while that's all well and good, usually that means that we end up using a measure that isn't really capturing the dimension of the behavior that we're most interested in, right? So how do we define aggression? Well, it might be something like, someone's fist coming from 6 inches away and making forceful contact that you can hear, right? That's one example of an operational definition for aggression. But really, what are we talking about? In that instance, that definition is based on the dimensions of distance, 6 inches or greater, and sound. Well, that really doesn't define what's aggression. The dimension of behavior that we're interested in when we talk about aggression is really the force of the impact, right? Like how hard, was it this or was it this really hard? That's what's telling us it's aggression or it's not. And so you can't really measure that very effectively with human observers. And so we rely on kind of some of these adjuncts to that or dimensions that are one step removed from what we're really interested in. And then in addition to that, it's expensive. I got to pay somebody, in some cases 2 people, to sit in a room and observe. Usually that means in a clinic as opposed to someone who lives far away. They have to travel to me, and it's just not a great fit. And so we've done a fair amount of work trying to replace or come up with ways to replace human observers using body-worn devices, in this case, accelerometers. And so an accelerometer really is, pick up your phone, you're probably staring at an accelerometer. Most phones have one in them. This measures motion in 3 dimensions on the X, Y, and Z axis. They're small, they're cheap. I'm told that the ones that we use, you could run through the dishwasher and they'll be fine. And so this is one of the things that we're starting to try to measure, because you think about accelerometers, one of the things they're really good at is measuring impact. And since we're measuring behaviors like aggression or self-injury or property destruction, hitting objects, hitting people, hitting yourself, accelerometers would be a really good measure for that. And just to give you a sense of that, here's examples of accelerometry data that we collected of instances of aggression on the left, disruptive behavior, hitting a table in that case in the middle, and self-injury. And you can see just from these small samples that there are some differences, right? So in the case of aggression, for example, it's a smaller amplitude than the self-injurious behavior. We have some hypotheses that seems to be because oftentimes when you're aggressing towards someone, that someone is oftentimes moving away, shielding themselves, blocking in a way that diminishes the impact. Whereas self-injury, a lot of our kids, they don't move away, they lean into themselves when they're hitting themselves in the head. And then in the case of disruption, when you hit a table, you see those little bounces after the fact, right? And so when hitting a hard surface, oftentimes your fist is vibrating after the impact occurs. And so using some machine learning techniques, some artificial intelligence to try to derive an algorithm, we've had kids now who have worn these accelerometers during these functional analyses that I showed you at the beginning of the talk, where we expect to see some of these challenging behaviors because we're kind of evoking it on purpose. And then taking those exemplars of, okay, when we have that person scoring, this is aggression, this is not, this is self-injury, this is disruption, feeding those data into these machine learning algorithms. And what they essentially do is become better and better at pattern recognition. That as you give them more exemplars, the algorithm becomes more and more effective at differentiating between those different behaviors. And so classifying aggression versus self-injury versus disruption versus none of the above. And so this is a heat map from some early data, and overall our accuracy is, yeah, it needs some work. But again, as we continue to give more and more data, these data sets, we think we're going to be better at identifying these different topographies of behavior and being able to, at some point, hopefully, be able to have kids wear these as opposed to have someone observe, so that they can be in their home as opposed to come to our clinic. Especially, I think when we discharge kids, we can continue to get data after the fact as opposed to having to send kids home and ask parents to collect data that they may not be able to do reliably. So we're hopeful that these data will continue to become refined as we work on that algorithm. So another type of research that, again, I think behavior analysts haven't been engaged in enough, especially as it relates to challenge behavior, is this question of implementation. And you've probably heard of implementation science. I'm always a little bit sketchy around anything you have to tell people that what you're doing science, that it's science. I think about political science. Is political science really science? It's got the word science in there, so it must be. So implementation science, though, really just this idea of understanding what is influencing the uptake of some of these interventions. And when I think about the type of work that we do addressing challenging behavior, that's really the central issue more than anything else, right? So I bring a kid to my clinic and I got red cards and green cards, and I can get the kid to behave well in clinic all day long because I got staff who are trained to implement this with perfect fidelity, and they're willing to take a hit if they have to because they can wear protective gear, and they know that there's 3 other people in the next room who could step in if they're needed. But that's not really going to produce the long-term outcome that I'm looking for. What I really want to see is that this behavioral change persists when the kid goes home. And that means training parents. And that means the parents have to implement these things with fidelity. And that's a tall order in a lot of instances, right? A lot of the time, the parent doesn't have the protective gear, doesn't have they don't get the break at the end of the day. And so they're dealing with a level of frustration and concern and anxiety around, can they implement this consistently? And what we see happening again and again is that parents have to make some pretty tough choices. And what we're looking to see is, to see these outcomes, we've got to see that the parents implement them with fidelity, which means they've got to be bought in. And so I think about, from my frame of thinking, that parent who's in the checkout aisle, right? They go to the grocery store and they go to the checkout aisle and their child throws a tantrum, and they think to themselves, well, I can do what Dr. Call told me to, and 6 months from now, my kid won't throw tantrums in the checkout aisle, or I could just give him the candy bar that caused this problem in the first place, give it to him now, and I can have quiet now. And a lot of parents are making the choice of that impulsive choice of give it to him now for the immediate but smaller gain at the expense of the longer term, where we know that by giving into the kid in the short run, that actually probably exacerbates things for that family. And so studying some of these factors that affect buy-in, this would be implementation science. And it's an area, again, that the behavior analysts haven't been sufficiently, in my view, focused on. And so something that we're trying to do some work in. And in particular, this idea of how does the delay to that treatment outcome drive the caregiver in their decision-making? So knowing that this is 6 months away, what if it was a week away? Would we get a different outcome from that caregiver? And so thinking about that led us immediately to some literature that's been developed in delay discounting, or sometimes called temporal discounting. And this is work that is based on really some well-established findings that people tend to just have a bias against delayed outcomes. The longer you have to wait for something, the less valuable it tends to be for you. And that really is true almost regardless of commodity. To a large extent, this research has been done doing parametric analyses with money as a commodity. And in fact, people have gotten it's been so well developed that they've looked at money and they give them hypothetical amounts of money. So hypothetically, would you rather have this amount of money or another amount of money? When they've looked at comparisons between what people choose for these hypothetical amounts of money and when they really give them the money, they tend to align so well that people just kind of have concluded that people make pretty good choices on these. And so they are comfortable using the hypothetical amounts. And then there's some real advantages to using money. One is it's easy to quantify, right? 1, 2, 5, 10, whatever, right? They're dollar amounts that are pretty well understood. And most people have similar experiences with money. I can buy the same cheeseburger with $1 that you can buy for $1. I wouldn't recommend eating a $1 cheeseburger, but there you have it. And so money is a pretty good commodity to try to assess in this way. And the way that typically works is, again, giving these choices between amounts that are available now or after a delay. And so usually might look like, would you rather have $1,000 now or $1,000 tomorrow? Most people pick the immediate choice when the commodities are of equivalent magnitude. But the very next trial might be, well, what about if it's $9.95 today or $1,000 tomorrow? And people might still take the $9.95 now, $5 difference. I may not see you tomorrow to pay up, so I'm going to go with the now. But at some point, people make a switch, right? And they'll switch from that in this case at 975, which we would call the indifference point. That's the point at which they switch as well. These two commodities seem roughly equivalent in the immediate magnitude, but the delayed larger amount. And so then we would repeat the whole process, in this case, starting at 1,000 versus 1,000, but at 1 week. What about that? Well, if it's 975 versus a week, I'm going to go back to the 975, and you keep going until you get that indifference point again. And so that says, well, when the difference between these two commodities is a week, that's the indifference point. And when you plot those different indifference points along a graph like this, what you tend to see is this monotonic decelerating curve, where you see the reduction over time. And you see that basically in the future amounts magnitude, what is today's dollars worth, right? So in 6 months, today's $1,000 will be worth some proportion of that. In this case, around $750, $500, right? And so that's what each of these data points show. And what's also been really interesting is when people have looked at these types of analyses, the kinds of populations that would seem to be more likely to be susceptible to delays influencing their choices tend to show those patterns, right? In this case, this is some data looking at smokers, and people who are addicted to other substances as well have shown steeper discounting curves, that their curves kind of look really steep, whereas somebody who isn't addicted might show a shallower curve. Same thing is true for kids with ADHD, pathological gamblers, folks who would seem to be more susceptible to delays. And so they've also done a lot of work to really come up with some well-refined quantitative models. In this case, this is an equation where you can plot most of the values here, like the value, the small v is the subjective value of the outcome, as opposed to the actual undiscounted amount, which would be $1,000 in this case. The small v would be what was the choice that they made. D, the magnitude of the delay. And then you can solve for this K term by doing a little bit of algebra, or use area under the curve to quantify how susceptible is this given individual to delays. And so this has, again, been mostly done with money, but people have looked at other commodities. One of my favorite studies was one where they asked people, would you rather have your ideal romantic partner in 6 months or somebody who's like 80% of the way there today, right? And I think about that as like some of those dating apps, right? That, you swipe left because, it's good enough for tonight. And so they've also done this, though, with health gains and losses. And they've looked at, this was a study that was done with college undergraduates where they had a hypothetical STD, and you have a treatment that could cure your symptoms for 6 months right away, or that could cure your symptoms for a year, but it takes 2 weeks or 4 weeks to have the intended effect. And so based on that literature, we did something really similar, asking caregivers what types of treatments would they rather have? Would they rather have a treatment that achieves 95% of their treatment goals now, or one that achieves 100% of their treatment goals in a week, a month, 6 months, a year? And when we plotted those data, and we also did the same analysis for money because we wanted to see how those two compared, we saw that parents made the exact same kinds of choices as when they're making choices about money. There do seem to be some differences. They seem to show a little bit more self-control when it comes to treatment, that they weren't as affected by delays for treatment as they were for money, but they were still showing the same outcome. And in fact, what we saw was that for a lot of families, if a treatment took as much as 6 months to have the intended effect, then it lost almost a third of its value. And when that's the case, a lot of these treatments do take 6 months to have a 100% effect, or even a big effect. And so if a family's having to make a choice like that, we have families who are telling us, well, if I have to wait 2 weeks, it's losing a lot of its value. That tells us a lot about what we as a discipline need to be doing to improve upon the work that we're doing. And one thing is to use data like this to we could just choose to only work with the families who show that they're not very susceptible to delays. That's not a very satisfying route. I tend to think we want to work with every family. And so another approach is to try to use these data and to assess parents and characterize them based on their sensitivity to delays, but then provide interventions to help increase their ability to kind of stick with the treatment. And that might mean that things like wraparound services, which can be really expensive and can't probably be deployed to every family, but could maybe be targeted to some of these families for whom we think that they are susceptible to delays, to give them the supports that they need to implement these interventions so that we can get the kinds of outcomes that we know are possible, but may not be likely if we don't have those kinds of supports in place for certain types of families. And then lastly, I think a real key is if a treatment's taken 6 months to have that effect and parents can't really hang with us for that long, then treatment's got to work faster. And I don't have a great solution for that other than we just need to continue to refine these types of interventions, because even though we know they can have big effects, they need to have them quickly enough for them to be useful to the people who have to implement them. So covered a lot of ground. I think at the end of the day, what I'm talking about is there's just different kinds of research questions, and where my field has traditionally been pretty focused is on this first set of questions, what's possible? And single subject methods are really good for that. And I think that's an area where we need to continue to do work, because that's where innovation happens. But it's not enough. We can't just stop there. It's important that we then start asking questions like, how probable are those effects? And that requires things like RCTs, and means more people have to be doing that type of work. It also means we need to look at how are these interventions actually implemented in the real world. Effectiveness research, which I haven't really had a chance to get into today, but another area where our team is working. But also, what's facilitating the uptake or impeding the uptake of these interventions, which take us into implementation science. So all worthwhile questions. Unfortunately, I think there's just been a little too narrow of a focus on a subset of those questions. And so what our team are trying to do here at Marcus is to expand that to tackle the entire continuum of questions, which means adopting the entire continuum of methods, so that we can try to improve the way that these kids and their families are able to function in our society, and give them a better quality of life. And so with that, thank you for your time. These are just a handful of the folks that have contributed to this work, but thank you for your time and your attention here today.